All right, we will go ahead and get started here. Welcome and thank you all for joining us today. I'm Lacey Coling and I'll be our moderator for today's webinar. I am a metastatic paraganglioma patient. I was originally diagnosed in 2018 with two head and neck paragangliomas. In 2023, I was diagnosed as metastatic, and I'm currently participating in a clinical trial with lanreotide at the National Institute of Health. I'm here today with Dr. Karel, Pacak and Dr. David Taieb. I'll provide a proper introduction in a few minutes. This program is brought to you today by the Pheo Alliance, whose mission it is to empower patients with pheochromocytoma or paraganglioma, their families and medical professionals through advocacy, education, and a global community of support while helping to advance the research that accelerates treatment and cures. We have some upcoming events. The nominations for the second annual Pheo Phenom Volunteer Awards open this Thursday, March 28th at 12 a.m. Pacific. Our next monthly peer support meeting will be held on Tuesday, April 2nd at 4:30 p.m. Pacific, 7:30 Eastern. Our fifth annual Pheo Awareness Week will be held August 26th through the 30th. Planning is currently underway, and if you're interested in volunteering, please contact us. Also, save the date. On September 21st, the Pheo Alliance will hold its annual gala in Hartford, Connecticut. You can learn more about these events on our website at pheopara.org. A disclaimer, the information presented on this webinar is for educational purposes only and should not substitute the advice of your doctors and medical team, because they have in-depth knowledge of your medical history and current situation. Dr. Pacak and Dr. Taieb will present for about 30 minutes and then participate in a Q&A with the community. We will ask all of the questions that were submitted beforehand, and you can also type your questions into the Q&A box accessible from the bottom of your screen. We will do our best to have all of your questions answered if time allows. Many people will ask variations of the same question, so please listen carefully for questions that may be similar. Questions that are less case-specific are appreciated. All right, now we'll introduce the doctors that we have with us today. Dr. Pacak is a board-certified endocrinologist and an internationally recognized expert in the diagnosis and treatment of neuroendocrine tumors, especially pheochromocytoma and paraganglioma. He graduated summa cum laude from Charles University, Prague, Czech Republic in 1984. He received his PhD in 1993 and his DSc in 1998 in the field of neuroendocrinology from Charles University. In 2006, he was awarded a lifetime professorship in international medicine at Charles University. Dr. Pacak established the International Symposia on Pheochromocytoma and helped co-found a New Asian Alliance for the Study of Neuroendocrine Tumors in 2010. He is a recipient of numerous awards, including the Peter Hyman Memorial Award at Yale University, International Association of Endocrine Surgeons, NIH Director's Mentor Award, Award for Cure from Pheo Alliance, the NIHCD's Director Award of Merit, Pincus Taft's Memorial Lecture, the highest award from Endocrine Society of Australia, and Genesis Gold Medal from Slovak Academy of Sciences. Dr. Pacak is also the author of more than 305 scientific peer-reviewed articles, 98 book chapters, and 5 books. Dr. David Taieb, MD, PhD, is a full professor of nuclear medicine at the Aix-Marseille University, France. He is a member of the EANM Oncology and Theranostics community. He holds numerous research grants, is the co-editor of 2 textbooks dedicated to nuclear endocrinology, and has over 240 peer-reviewed publications at PubMD. A major focus of Dr. Taieb's clinical research, in collaboration with the National Institutes of Health, has been to improve disease characterization by molecular imaging of pheochromocytoma and paraganglioma. In addition, he is actively involved in the therapeutic nuclear medicine with a major focus on endocrine neoplasms. He is also affiliated to the INSERM, the French Institute of Health and Medical Research, with several ongoing basic research projects on nanomedicine and nucleic acid therapeutics. He coordinated the EANM Practice Guideline, SMMI Procedure Standard 2019 for radionuclide imaging of the paraganglioma and was a co-chair of the effort that produced the updated guidelines that we're discussing today. Dr. Pacak and Dr. Taieb, welcome. We will switch over now and start sharing your screen.
Okay, so good morning or good afternoon or maybe even good evening, for somebody. And first of all, I would like to thank Lacey for very nice and I would say touching introduction. So very much appreciate that. Today, together with Dr. David Taieb, we will present the talk, recent international guidelines on management of carriers and Pheo patients with SDH pathogenic variants. I wanted to say upfront that, it's not only our work, this is international actually effort, that was supported actually by excellent physicians focusing on pheochromocytoma paraganglioma. And then you will see, from the presentation who are the physicians involved, in those guidelines. I hope that we will give you some very interesting update on pheochromocytoma paraganglioma in terms of the carriers, with these very complicated pathogenic variants, but also, some very interesting views, how we would approach patients with these tumors, whether they have especially, the mutation, which is called SDHD or SDHB mutation. So about, the international consensus on initial screening and follow-up of asymptomatic SDHx mutation carriers. And here I would like to give credit mainly to Dr. Laurence Amar and Charlotte Lucy Leperter, who actually put a lot of effort, into this activity and working and focusing how we should approach patients with SDHx who are actually carriers, but they don't have pheochromocytoma and or paraganglioma. So first of all, I would like to say that, and I will present only some few most important parts, from those guidelines. And the first is about the tumor screening that should be performed after the identification of the mutations, whether, we are talking about SDHA, B, C, or SDHD father inherited. And that's very important, because, the tumor screening should not start before the identification of these mutations. Then, first tumor screening should be performed a little bit different way. When we talk about the patients, I mean here carriers, with SDHB pathogenic variant, we should start a little bit earlier, and the international consensus and the experts agree that that should be somewhere between the age 6 and 10. For other, the pathogenic variants should be between the age 10 and 15. Tumor screening. So in asymptomatic SDHx mutation carrier should include clinical examination. The clinical examination is absolutely very important. We are usually looking on symptoms and signs that are related to catecholamine excess, including, for example, blood pressure measurement. So when you look at the symptoms and signs, for example, looking for headache, looking at the sweating, or for example, the patients have, for example, palpitations. But what is interesting for the first time ever, in the guidelines is something about the weight loss, and especially unexpected weight loss, which is very important and was published, especially by Europeans, and I will mention something about that. Also, the biochemical testing, so it's very important. You remember that before we had, for example, plasma or urine catecholamines, and methanephrine's, but these guidelines for patients with SDHx pathogenic variant should not actually involve anything else than the measurement of plasma or urine methanephrine's. And exceptionally, of course, we can measure 3-methoxytyramine in the plasma, but the problem is the 3-methoxytyramine in plasma is not really available at many places, and especially in US, because in US it's only most likely, the National Institute of Health, NIH, that, measure 3-methoxytyramine. So the biochemical testing right now should not include any measurement focusing on vinyl mandelic acid or catecholamines. So the catecholamines, remember, especially catecholamines, because VMA, vinyl mandelic acid, is usually not done, but the catecholamines, I see it over and over, that are measured. Of course, at the NIH, we are measuring because, we are doing, some specific research, focusing on the biochemistry, but otherwise, if you as a patient are outside, always ask about methanephrine's either in plasma or urine. I would like to say something about the clinical characteristics that I mentioned before, because, the patients are actually coming, to physicians, and they have some symptoms and signs of what I mentioned before that are related to catecholamine excess. And when you see, this figure, you can see that there are some cardiovascular problems, and, the diamond, they know differences between those patients that they have a paraganglioma/pheochromocytoma and those without these tumors. And for example, as I mentioned before, palpitation, tachyarrhythmia, but look, at the hypertension. Hypertension is not actually clinical characteristics for pheochromocytoma paraganglioma, and I will explain it very shortly. But when you look at the other problems that they have, is definitely sweating, tremor, weakness. Some patients, they have some paleness, which is very important. The sign, not very common sign, but the catecholamines can constrict the vessels, and especially in face, some patients can be pale. What is also important and not very much appreciated before is nausea and vomiting. And of course, we know if the patients, they have a high catecholamines, then they may have a constipation. And then finally, as I mentioned, the weight loss is very important. So what is interesting, and this is coming from the paper from Gerola and co-workers, that if you have 3 or more symptoms and signs, and they include hyperhidrosis, which would be, the sweating, palpitation, pallor, tremor, or nausea, and if it is combined with body mass index that is less than 25, that means that the patients are, losing weight, and a heart rate above 85 per minute. Those patients, they have approximately 7.5-fold increase, the more likely to have the pheochromocytoma and paraganglioma. Sometimes patients are asking me, but I have a hypertension, how come that I don't have a pheochromocytoma paraganglioma? And I will tell you something that you have to always keep in mind, especially, for the patients, because I think, healthcare professionals, they know about that. So the patients, they don't have actually, even they have a drug-resistant hypertension, so, and they are evaluated for pheochromocytoma paraganglioma. This evaluation is not really well justified unless, this hypertension is associated with symptoms and signs related to catecholamine excess. So if the patient is coming and tells you that the patient has only hypertension, so even if it's difficult to treat the hypertension, most likely the patient will not have a pheochromocytoma or paraganglioma. What is also interesting, how we view actually and how we diagnose the patients with pheochromocytoma today, because, many years ago, of course, we look at the symptoms and signs, related to catecholamine excess, because the CT and MRI was not actually so much available. And later on, and you can see, especially, during the years 2007 and 2018, so we are actually diagnosing, these patients very often based on the imaging. So incidental findings, the patients are coming to doctors, for whatever the reasons, and there is, for example, adrenal incidentaloma, but incidentaloma can be also outside the adrenal gland. So today, the number of those tumors, Pheo versus paraganglioma, is diagnosed by CT or MRI, at least in 50 and maybe more than 50% of patients, compared to, for example, based on the symptoms that used to be about 80%, just now is 40%. And of course, genetic is playing very important role. And, approximately 10% of patients are just now diagnosed based on genetic testing. What about the tumor screening, for these SDH mutation carriers? So include the imaging. But if you look at, this, the table, you can see that we are not recommending any CT scan, to be done in carriers. If you do something, you do the MRI, and of course the MRI is very good because, decrease, the radiation exposure because there is no radiation exposure. And otherwise in pediatric patients or adult patients, we usually prefer whole body MRI scan. That is very important because those paragangliomas can be actually in any part of the body. When you look at the PET scan, it's not recommended for children, but for the children you can do sometimes ultrasound, and you do the ultrasound if, for example, patients they cannot tolerate the MRI, or for example, sometimes you can do it also in pregnant women, especially as a first test to see, what is going on. The PET scan is actually suggested only in adult patients. When we do the follow-up for these carriers, the follow-up is very important. So you do and you collect the blood, you do the blood pressure measurement as well, together with a questionnaire. And of course, the collection of the blood, so includes, the biochemical investigation. And patients should have also the MRI, because I told you that we don't suggest the CT scan, but we suggest the MRI. But what is important, if you look at the children on the left side, the algorithm, so every year, of course, we look at the blood pressure and we do the questionnaire, but the children can have only every 2 years, the measurement of plasma or urine metanephrines, and every 2-3 years, they should have an MRI. But in adults, it's a little bit different, so what I said about the children, that they will have, every 2 years, the measurement of plasma or urinary metanephrines for adults will be every year. And the MRI will be practically the same, whole body MRI, and that would be every 2 to 3 years. If those patients are doing very well and they, for example, never develop any tumor related to SDHx deficiency, and they are asymptomatic, so we can actually adjust, how often the screening test will be done. And if they reach the age 70 years, usually the screening can be done every 5 years. And if they reach the age of 80, we can stop the screening. There are some few more recommendations, and the recommendations about the pregnancy. If there is a suspicion for pheochromocytoma paraganglioma, whatever the reasons are, so a complete screening should be performed before planning pregnancy. So the patient should discuss with her healthcare professionals if they are planning pregnancy and how to approach everything in terms of the screening and in terms of also the imaging studies, and to discuss the results. If we have a follow-up, the patient, sometimes the questions come, could I have, the different follow-up if my parents, for example, develop metastatic disease, or metastatic pheochromocytoma paraganglioma, and they are now different actually approaches at the present time. Of course, if we would do, very large international study, we may come up, with a little bit modified suggestion, but at the present time, we don't have a good evidence, to make, a little bit adjustment for this group of patients. And of course, SDHx patients, they have other tumors, like, for example, GIST, or they have a renal cell carcinoma. And the question is, whether we should, do something additional. And the response is there are no additional imaging studies that should be performed for these tumors. And the reason is that those tumors are coming not very often. They are pretty much very rare, and if there is any suspicion, of course, imaging can be added. And I will stop here, and Dr. Taieb will present SDHD.
Yes, can I share my screen? Yeah. So hello and good morning, and thanks for the invitation. So we are now discuss the management of patient who has Pheo or paraganglioma in the context of SDH mutation. So it is recommended that patient with PPGL and germline SDH pathogenic variant be evaluated by both clinical assessment and biochemical measurements. All should be performed together. Importantly, since patient with SDH mutation may have most of the time head and neck paraganglioma, but could also have some thoracic paraganglioma, but also extra-adrenal abdominal paraganglioma, and sometimes pheochromocytoma, we need to perform a whole body anatomic imaging together, and this is important in the context of SDH mutation, with PET imaging, and preferably with somatostatin receptor PET imaging, because this is the most sensitive functional imaging modality. A very important recommendation is that when we have a patient with newly diagnosed head and neck paraganglioma without compelling indication for treatment, we should have an initial trial of observation to try to characterize tumor behavior. This is really a crucial recommendation. It was also suggested that patient who has been surgically treated for primary functional PPGL continue to be evaluated by plasma or urine metanephrines and plasma methoxytyramine every 8 weeks post-treatment. And imaging could be done at 3 to 6 months after surgery. Importantly, it was also recommended that the patient should undergo annual blood pressure measurement, clinical assessment, and biochemical measurements to detect new PPGL, metastasis, or disease progression. It is also important to perform whole body MRI every 2 to 3 years to detect new PPGL in this context, or metastatic disease or disease progression. Initially, and this should be determined on an individual basis, initially more frequent imaging follow-up is recommended for patients with unoperated PPGL or metastatic disease. As you know, a patient with SDH mutation are a very high probability to develop head and neck paraganglioma. And we have different scenarios, and all of these scenarios are completely different. We have temporal bone paraganglioma, which includes tympanomastoid paraganglioma and or jugular paraganglioma, or lateral neck paraganglioma that includes vagal paraganglioma, carotid paraganglioma. And you have to consider that all of these different tumors are completely different scenarios and completely different kind of management. And most importantly, you know that in patients with SDHD mutations, there is a very high risk of multifocality. And even if you are a single paraganglioma in the neck, you have to consider that the patient is at risk to develop, for example, a contralateral paraganglioma. And this will clearly influence the management of patients. The golden rules are, before any further discussions takes place among expert interdisciplinary team meeting, a comprehensive workup that should include both all clinical, biochemical, morphological, and functional imaging should be conducted. If you want to have a clear picture of the clinical scenario, you have to perform all. All patients should be offered surgical consultation with an experienced surgeon to discuss resection with regard to risk-benefit balance. Without compelling indication for surgical treatment, an initial trial of observation to characterize disease tumor behavior is highly recommended. First, do not harm. And importantly, a lifelong follow-up is required for all patients. As you know, the clinical scenarios are different and the decision-making process is complex, and many different parameters are important to be discussed when you are faced to a patient with head and neck paraganglioma, based on clinical evaluation, imaging, previous report, previous imaging study, knowledge on the genetic status, a complete cranial nerve examination and laryngoscopy, a complete biochemical evaluation, a complete clinical evaluation. And patient preference is very also important. For example, when you have to manage a patient with corrected paraganglioma and there is a bilateral tumor, you can discuss surgery, but you have to perform a stage approach for. In this situation, sometimes some team starts surgery on the smaller, less aggressive sites, and after the patient has to be completely reevaluated. And if there is no postoperative cranial neuropathy, we can, for example, consider surgery on the contralateral side. But if there is some postoperative neuropathy, we have to discuss different approaches, such as stereotactic radiosurgery, conventional radiotherapy, or observation. For vagus nerve paraganglioma, it's completely different. Vagal paraganglioma should rarely be considered for surgery due to the high risk of vocal cord paralysis. Surgical intervention on such lesion is generally only performed after the vocal cord is already immobile. In other situations, surgery, surveillance, or therapeutic radiation should be considered. So remember that vagus nerve paraganglioma patient should usually not be operated, except if there is vocal cord paralysis that precedes surgery, or in very large tumor, or maybe sometime in the context of metastatic disease. The management of jugular paraganglioma is really complex, as this tumor can lead to devastating consequences before surgery. Surgery is very challenging and requires to combine very different expertise, ENT, neurosurgery, vascular skills. Therapeutic radiation often leads to a height like wood of stabilization, but we have not really very long-term surveillance in this context, and this could be complex in the management of young subjects. Gross total surgery should be performed on an individual basis with the option of subtotal resection with or without irradiation of residual tumor to avoid profound disability. And preoperative tumor embolization is always necessary. Therapeutic radiation should be considered as an effective treatment option for patients with unresectable disease or unresectable surgical risk. Stereotactic radiosurgery is the recommended method for therapeutic radiation. Conventional radiotherapy could be recommended for patients with very large head and neck paragangliomas. So it's for you, Karel, now.
Okay. Okay, so thank you so much. So I will continue with SDHB, and I will say some few words about SDHB. I know that the time is limited, so I will try to speed up a little bit, So as you know, for SDHB pheoparaganglioma for all patients, so these tumors have a highest rates of the disease-specific morbidity and mortality. What is interesting are these tumors that don't produce substantial amount of catecholamine. So sometimes patients are coming later on because if they have, substantial amount of catecholamines in their tumors, the tumors are already bigger. So we can see it, very often, in many patients. So they have to, the tumors 4, 5, 6 centimeters. This is not their fault. This is just, that they don't have any symptoms and signs that would be related to catecholamine excess. And as you know, that they have a little bit high metastatic rate, it's approximately 40%. It depends what you read approximately, but also what is problematic that patients who are initially presenting, about 25% of these patients, they have a synchronous metastasis. So it's something, complicated because, those patients need, sometimes, treatment right away, and, surgery option is sometimes limited. So if we can go to recommendations, for the patient with SDHB, so what is important, surgical resection. Should we do the minimally invasive surgery? Should we do a resection via an open approach? And we actually prefer usually surgical resection via an open approach, because there is a risk of a future local recurrence of metastasis, because I told you that these tumors are actually more aggressive, and they are not only more aggressive in terms of metastatic disease, but they are also more aggressive in terms of locally. And you have here the box 1, and it's suggesting when the open surgery should be actually considered, especially larger tumors like, 4 centimeters or larger, if there is, for example, lymph node involvement, but they have also, some other indications, for patients who should have open surgery. What is important for patients, and please remember that if you have for example, pheochromocytoma in the adrenal gland, if you have a SDHD pheochromocytoma, if you have a VHL-MEN or something like that, physicians usually try, to do corticosparing surgery. And the reason is because, to avoid, steroid replacement in the future. But, for the SDHB, it's a little bit different. So number one, as I said, those tumors are very complicated. They are growing sometimes very fast. They are aggressive locally. They can actually, or they are associated with metastatic disease. So the corticosparing surgery is not actually recommended for patients with adrenal pheochromocytoma that is related to SDHB. What is good for patients, to develop the SDHB-related pheochromocytoma on the contralateral site is practically zero, so it's very, very rare. So they don't have to be actually, or they don't need to worry so much about, the cortisol replacement, lifetime replacement, because they will have another, the adrenal gland. And even if they lose, the adrenal gland where actually pheochromocytoma SDHB1 actually is located. But just remember that because it's important. So the evaluation is pretty much like, for SDHD, whether you have a MRI or CT scan. Sometimes we prefer, the CT scan, but what is important after surgery? All the patients after surgery for SDHB, Pheo/paraganglioma should have evaluation with CT and MRI approximately 6 months after the surgery, and they should have the dotatate scan, so also within 6 months after surgery, especially if it was not done preoperatively. If it was done preoperatively, sometimes it's not needed, because you have a CT or MRI after the surgery. And if there is no any evidence of the disease, so you remember, so patients, for example, the SDHD, can have it every 2 or 3 years, so, but, the patients with SDHB, because they are more complicated, difficult, aggressive, we suggest, to have, whole body MRI scan, to be performed every 1-2 years after, surgery. About, the therapy very quickly, I just wanted to say that we still recommend CVD chemotherapy as the first line for patients. They have a progressive SDHB-related pheochromocytoma, paraganglioma. Believe it or not, with CVD chemotherapy works very well, and patients are responding truly very well, to CVD chemotherapy. It's all type, chemotherapy, but works very well. If those patients, they have for example, metastatic SDHB pheoparaganglioma, but this is slow growing, or, even, moderate growth. So you don't have to actually think about the chemotherapy. You can think about the radionuclide therapy, and we are using either MIBG or PRRT, and I will mention something about that. And this will be especially, with the Lutathera. Just only, for a few more slides at the end, just wanted to tell you that the Pheos are really, very interesting because they have a transporters or receptors. They are very useful, for not only imaging, but also for radiotherapy. Those receptors like somatostatin receptor, this is why, you are hearing about the dotatate, either gallium dotatate for the scan, or, for the with the lutetium for the therapy, or they have a, so-called norepinephrine transporter system, and, the MIBG, again, either, for the diagnostic purposes, or, for the 131 iodine MIBG for the radiotherapy. So we have also the cluster-specific functional imaging. I think it's very important for patients. If you have, for example, something related to SDHx, and we are talking today about SDHx, or, metastatic pheochromocytoma, regardless, whether it's sporadic or SDHx, metastatic pheochromocytoma, always the dotatate. If you have something related to cluster 2, for example, some patients may have a VHL, they have a MEN2 or MEX gene, we usually suggest the fluorodopa. Problem is the fluorodopa is practically not available in the United States, but is available at the NIH. Sometimes patients are asking, should I have a gallium dotatate? Should I have a copper dotatate? And I can tell you that it's very short, very small study with only a few patients, but you can see that there are no differences. So either one, the radiopharmaceutical will be okay. So don't only insist to have a gallium-68, you can have also copper, and most likely the results will be the same. And finally, I would like to say that, about when we talk about theranostic, because you sometimes hear, the concept or this word, it's, combines therapy and diagnostic. I already told you, the diagnostic is when we use, the scan to diagnose the disease and through, certain target. And the same target is used also for the therapeutic purpose. And for example, it's this gallium 68 or lutetium-177, whether you are talking about diagnostic scan or when you are talking about, therapy. And just, the efficacy of, those modalities, if we are talking about Lutathera, patients have a pretty good response, partial response, stable disease, 90%. We used to have Azedra, but unfortunately will be close, next month, and it's about, the same outcome, 92%. But don't be scared, don't worry so much, because if you use the low specific activity iodine 131 MIBG, that we have a lot of experience in this country because it was developed in this country at University of Michigan. The data are very good, so approximately 82% of patients will have partial response or stable disease. Yes, we are not at 90%, but 82% is still very good, so the difference is not, very huge. There is some difference, but the difference is not very huge. So I would like to finish here, because we have many questions, and I would like to thank many, scientists and many others, being, around, but especially Dr. Samar, Lucy Lepoutre, and Dr. Lendres, because they really, truly supported and participated in writing guidelines, especially, with their comments, and especially also putting together the guidelines related to carriers with SDHx pathogenic variants. So I will stop here, and thank you very much for your attention.
All right. Thank you both so much. All right. We'll jump right into questions. The first question that we have is, which type of panel is the best for testing for all types of variants of SDHx as well as others?
So the panels, there are different panels, so because there are different companies, so for example, the NIH is using Invitae, so which is very good company, with reliable results, the turnover is very quick, here, approximately 10 days, but there are, for example, GeneDx and many other companies. It depends, where you are living, so because there will be definitely some other options as well. And also European companies are different. I cannot comment about European companies, but there are, gene panels that they have to be always focusing on pheochromocytoma paraganglioma. And if you can get, the panel, not all these 20-25 genes that are involved in the pathogenesis of this disease, they actually focus at least or ask, for the 12, the most common. And the good thing is that in those 12 most common SDHx genes are all included. So except for sometimes companies, they don't have a SDHA because it's a little bit more complicated. So always check if they have a SDHA. But I think, these days you should be okay. Also, Mayo Clinic is doing extremely good job here in the United States, but double check on SDHA just to make sure it's included.
All right, thank you. Across the genetic variants, what is the risk of ascertainment bias? If genetic variants have largely been detected from people with clinical symptoms, how many variants may be out there but clinically silent? Ascertainment bias.
Yeah, clinical variants, clinically silent. Yeah. So of course, this is again related to SDHx. But why are they clinically silent? Because, those tumors are differentiated and they don't actually produce catecholamines, or if they produce catecholamines, they sometimes produce only dopamine. just, for our patients, if you have an epinephrine or epinephrine that are produced, they can actually make the symptoms and signs, but the dopamine will not. So if you have a tumor that is less differentiated and producing only dopamine, you will be coming to the physician not actually with symptoms and signs related to catecholamine excess, which means, you will not have high blood pressure, palpitations, sweating, etc. Most likely you will come to physician because you will have a pain. And why you will have a pain? Because your tumor will be large. Okay, because you did not know anything about the tumor and tumor was growing. Okay, so this is actually the difference. How many? Approximately 3 to 5%, from all, these tumors with SDHx, so sometimes, some papers are showing, maybe 7 to 10%, but I don't believe it. I think it's approximately 3 to 5%.
All right, thank you. Would the germline and somatic SDHx mutation be different?
That's also very interesting. David, can I comment about that, or you want to comment about that? Either one, so.
Please.
Yeah, so the germline somatic, they are not different, except for, if you have a germline, you have it everywhere in the body. So you will develop, head and neck paraganglioma, you develop pheochromocytoma, you will develop, for example, paraganglioma. If you have a somatic, by the way, somatic is extremely, extremely, extremely rare. Okay, so, and sometimes almost non-existing. Okay, there are some reports, yes, and good reports, but overall it's extremely rare. But if it is somatic, usually it's on a certain place, so I will not go into details how it is happening. But for example, if we find it in pheochromocytoma, yes, patient has, somatic mutation in the pheochromocytoma or paraganglioma, but this patient, will be spared from, from other tumors, most likely. Okay, so it's a much better outcome that, for example, if you have a germline mutation.
Okay. And then is there any evidence that following a particular diet is better for preventing tumor development in anybody with SDH pathogenic variants?
Well, I don't know, David, or I will comment, or, but I can tell you honestly, if I would know, I would like to learn from the patients, but, the diet, most likely not, very good. Maybe a lot of antioxidants that are what I suggest, but this is my personal view, please, so this is not something that is very well studied and very good evidence. And not only diet, but where the patients are living. I definitely do not suggest patients will be living in high altitude. Again, my personal view and Dr. Baisal's view, who actually discovered SDHD, and some other physician or scientists as well. High altitude is definitely something that I don't recommend. But in terms of diet, it's instead of the antioxidants, vitamins, etc. So I don't think that there is something else that it is coming through my mind.
All right. I'm going to combine the next two on here. They're both about SDHB, and they're asking whether the mutation can skip generations. And then one, they're one of 7, and all of the siblings have SDHB, but only one of the parents has SDHB. Is that something common or unusual?
It of course can skip generation, but it does not skip generation. It depends, whether, the mutation will be, present in, for example, parents. One of the parents has, the mutation. There is 50% chance approximately that, their children will have the mutation. They may be lucky and none of these children will have the mutation. And then nobody will have, the mutation, later on, because children, they don't have a mutation and you stop there. So, but it's usually not happening. If they have 2, 3 kids, at least one of them, has the mutation. So skipping generation, definitely not. But for SDHD, where is maternal imprinting, there is definitely skipping generation for SDHD.
All right. And then are there any updates to the SDHB Carney triad?
To my best knowledge, for SDHB Carney triad, yes, there are, some not really very huge update or something, very new, but we know that, for some patients, they could have, epigenetic mechanisms, that could actually silence those genes, from like almost outside, with through the mechanism which is called methylation. And so that could be actually, but otherwise, yes, there was something, published just recently, I think, from Brazil. And I would suggest, the person, to look at that paper, from Brazil. They are talking about, some gene that could be actually involved in the Carney triad. I cannot just remember the gene.
I don't know it either. The next question is also about SDHB. It says, we just had our first baby. The father has SDHB and a paraganglioma. How should we proceed on timing? Testing our son for the gene and surveillance if he also has it.
Yeah,
So the question, yep.
Yeah, as I said, between 6 and 10 years, to perform, genetic testing. And then, so put this way, the genetic testing can be done anytime, so this is only a recommendation. But, if you do genetic testing, you have to make sure that you will follow up, with the imaging. Okay, if you think that your child does not need, to start, with imaging, and also at that age, so there is no reason, to do genetic testing. If you know that your child will undergo, genetic testing, so I mean genetic testing, imaging studies and biochemical testing, then of course you can test your child anytime you wish. You can test, child, few weeks after the child is born. Doesn't matter. So, but of course you will know the diagnosis, or you will know something about your child, immediately after the child is born. Okay.
Okay. We had a pre-question and a question in the chat on, you spoke about inherited SDHD from the paternal side, and there's a question about screening recommendations for maternally inherited SDHD.
I think Dr. David Taieb will answer. It's most likely.
Yes, I can. The risk is very low.
Mm.
The risk is very low, so yes, I'm not sure that we need to perform a really large screening for this patient, but it's never impossible to get. Personally, I have never seen this kind of inheritance, but sometime I have performed some imaging for a patient with maternally inheritance, but I never found any tumor. So I think that the risk is very, very low. So the recommendation should not follow the classical guidelines. Karel, could you complete?
Yeah, I think, there are some few reports, like, I remember 2 or 3 reports, from the, from, even there is maternal imprinting, for the SDHD, but I don't know, how everything goes. I can tell you, we have been here, over 23, 25 years. We never had anybody, who would have a SDHD, and in terms of, the mother and the children will develop, the disease. They can carry of the gene, and of course, mutated gene. This is no actually question about that, but they don't develop actually disease because of the methylation. So, the concept is a little bit complicated, and this is not for this audience here right now, but I think I can assure you that your chance, if you are mother with SDHD, your children will have, pheochromocytoma, paraganglioma, is almost 0.
Okay, thank you. This question is about a newly diagnosed bilateral carotid body tumor and an inherited SDHd gene mutation, how important is it that my healthcare team has specific experience with this type of tumor? Is it safe to move forward with a team comprised of an experienced ENT and endocrinologist, but no specific experience with this tumor?
Yeah, I think for carotid body we have to say that for me it's less complicated than the management of jugular paragangliomas. It depends. In some team, vascular surgeon take care of this tumor. In some teams, it is based on the experience of ENT surgeon. So it clearly depends on the situation. The most important is to be sure that there is only carotid body and only bilateral carotid body, because if you have additional vagus nerve paraganglioma, it is clearly not the same scenario. So the first is to have a clear surgeon team with a clear experience in carotid body surgery, and it's not the same skills that for jugular paraganglioma. Okay, it could be vascular or ENT. Both can be a good option, depend on the personal experience. First of all, you have to have a very nice and with a state-of-the-art imaging, preoperative imaging workup that should include MRI and PET imaging at least. And you have a great connection, a good connection with endocrinologists. And all the decisions should be discussed in the context of multidisciplinary team meeting. You have to have all the combinations. So it's really important. So for example, if you have a surgeon who has a great experience with a carotid body surgery, but no connection with endocrinologist and a bad preoperative imaging workup, I think it is not a good option. You have to have all of the package: endocrinologists, good surgeon, good preoperative workup, and all connecting all together in the decision. So it's crucial.
Yeah, I agree with Dr. Taieb. High volume centers, and I tell all my patients, although, some they listen, some they don't, so what is rare belongs to places where it is common, so, and if you still want to go to place, where there is no very good multidisciplinary team, so you may end up with complicated situation. Your question was about bilateral tumor. It's even more complicated than you think. It's a very complicated scenario, which site, you will start on. And we don't have a time, to discuss, but with Dr. Taieb, we will be happy to discuss, your case or your situation, sometimes, if you send us email. And then also through Pheo Alliance, we have a centers of excellence. You can actually contact those centers of excellence. Really, you have to be aware, like everybody else, you have rare disease, don't go to locally just, because it's convenient for you. You may end up with very complicated situation.
Awesome. Thank you for that great advice. And just a quick admin note for everyone that's on. We're going to continue going on into overtime answering questions, so please feel free to stay on. The next question is about paraganglioma specifically. If you have a para that's close to your intestine or colon, anywhere in that area, can it cause gastrointestinal problems? Currently have an SDHd with bilateral paras of the neck.
Yeah, so if you have it close to colon, so it depends, whether there is mass effect or not. If there would be mass effect, of course it does, and you can end up, with complicated situation, not only, for example, constipation, but you can end up with, for example, ileus, and some other clinical consequences. So on the other, so whether, your tumor around the colon is secreting catecholamines or not, because if secreting catecholamines and they are high, you will definitely end up with constipation and sometimes with severe constipation. So it really depends on the situation. It's very difficult, to comment from distance, but I think that you may have, several problems, and of course, including, for example, pain, etc.
All right, thank you. This question is, please weigh in on the controversy of screening for patients or families with incidental SDHA.
Yeah, so that's a very interesting question. So penetrance for SDHA is very low, so I maybe sometimes a little bit in contradiction with, some authors, that are saying, it's 7 to 10%, in our hands, it's extremely low. But, maybe we may have, a little bit different population. So I don't think that, those reports are wrong or right, I'm just saying, that the penetrance is low. What it means for patient? If penetrance is low, the chance to develop SDHA-related pheochromocytoma paraganglioma is the lowest from all the subunits that you may have, which are, BC and D. So yes, for carriers, we suggest what I actually presented, but I can tell you honestly, even if you do a little bit, I would say, more flexible follow-up, but you have to have at the first screening, you have to have at first, the MRI, whole body MRI, etc. But if you do a little bit more flexible screening, I think that would be okay. We did not put in the guidelines for whatever the reasons were, because it would be very complicated. Data is missing, evidence is missing, but based on the experience, I can tell you that to develop pheoparaganglioma extremely low. But if somebody develops SDHA paraganglioma, especially paraganglioma, Pheo is not very common, so they may be in problematic situation, because if those patients develop metastatic disease, it's very hard, to treat, the SDHA metastatic disease. I don't know why, but it's harder than, for example, SDHB. Again, my personal experience.
Okay. So this question comes from, they are the first person in their family to have head and neck paragangliomas and an FH mutation. They've had genetic testing, but since then, 2 other family members have also tested positive for the FH mutation. Is your advice that they should have any type of screening? Their physicians are saying that no screening like MRI or CT is necessary.
Well, for the FH, it's not common, for head and neck paragangliomas, but of course, FH comes, with moderate risk for metastatic disease. So therefore, my approach would be definitely screen, family members, for the presence of pheochromocytoma paraganglioma. Be aware that there is moderate risk. There is no low risk. This is not the highest, but this is moderate. Moderate, sometimes can be about 10% plus minus. So you have to be aware of that. There is very nice paper from France, from Anne-Paul Jimenez Rockapello and the others, so you have to be very careful. Okay. So I would definitely do the screening.
Thank you. What types of treatment options are there available for patients with paragangliomas, such as of the carotid artery? And what are the long-term side effects of those treatments for inoperable paragangliomas?
First of all, you have to be sure. It depends. It's in the context of SDH, or if it's in a context of sporadic. If this is in a context of sporadic, you have to be sure that it is really inoperable. You have to be sure that to see the right team, to be sure that it's really inoperable. It's crucial. If it's really inoperable, you will go to radiotherapy. You will go to radiotherapy. This is the first option. If there is any metastatic disease, and it's inoperable, and it is a large tumor, So you will probably go to radiotherapy, stereotactic. And if you go to radiotherapy, you have to be sure, if you want to limit the complications, that you will be submitted to the right procedure. And the right procedure should firstly go to stereotactic radiosurgery. So you have to go to a center which is able to provide this kind of modality. Unless if it's a very, very large carotid body parenchyma, and you have to go to classical, traditional, fractionated external beam radiotherapy. But if it's not a very large parenchyma, but it's an invasive parenchyma, and you are first sure that it is an operable tumor. Second, that you have access to stereotactic radiosurgery, so then you can go to this kind of treatment. With this kind of treatment, the risk of cranial nerves complication in the context of carotid body parenchyma is very low. And you have to continue to follow the patient with imaging to be sure that the patient will not develop any additional head and neck parenchyma, potentially metastatic disease. So first, surveillance. If you have the demonstrations that the tumor progress, you have to go to radiotherapy and be sure that you need first to be sure that really the tumor is not unresectable. And if you go sometime to the right surgical team, tumors that were previously classified as unoperable can be really operated. So it's important to go to a very large experience center.
That makes sense.
In the context of carotid body parenchyomas.
Okay. And there's another question for you, Dr. Taieb. It was based on the initial screening guidelines, what would you recommend for an asymptomatic patient with an SDHd mutation whose MRIs have shown very small, questionable nodules that could mimic enlarged lymph nodes in the head and neck? Would you recommend scans every year or every 2 to 3 years?
First of all, I would recommend to send the imaging to a large center with an experience to be sure that there is, because you know the classical anatomical location of the parenchyma is not the same as that lymph nodes. So we don't have so many situations where you are not really able to distinguish lymph nodes from a parenchyma. And there is also some typical features on, MR angiography and the context of PPGL patient or SDH mutation carrier. So, first of all, you have to be sure that the MRI has been done with a state-of-the-art, procedure. And if you have all the sequences, you have to be sure that it has been interpreted by a good radiologist, and be aware that there is so many situations when lymph nodes could mimic any parenchyma. Is not so frequent. Yeah, and if after reviewing of the MRI, still have adopt, so you can move to because it will improve the specificity of the imaging investigation.
Okay, thank you. This patient had a Pheo that was removed at age 27. Now at the age of 58, they've been diagnosed with a paraganglioma. They also had radiation therapy, and they're still awaiting the results of that. Their question is, will they get a paraganglioma again in their lifetime?
Oh, most likely if the patient had pheochromocytoma, then paraganglioma, so most likely it's genetic problem, something related to genetics. So I would need, to know what is, our genetic results. But I would say the answer is yes, there will be most likely the risk, to develop either pheochromocytoma or paraganglioma in the future.
Okay. And then how to manage the metastasis of PPGLs with no detectable lesions or mets? Does PRRT help, assuming that the patient is symptomatic and biochemical testing is positive?
Well, I am not absolutely sure if I understand how to manage metastatic disease if there is nothing, on the imaging and, biochemical tests are positive. Is that, and maybe there are some symptoms and signs. Is that correct, what you
Yes,
said?
that's what I'm reading. They're saying that they do have symptoms and their biochemical testing is positive, but they don't have any detectable lesions or mets.
Oh, how can be metastatic disease? Is not metastatic disease unless I assume that you had a CT, MRI, and most likely rotatate scan if necessary. But the most important, what you have to actually look, what kind of medication you are taking, because the medication that, for example, antidepressants, even medication for cold, medication like some food, some type of food. They all can cause, the false positive results. The position of the when, you will be, you are, or you were testing, because you have to have a recombinant position for at least 20, 30 minutes. So it really depends. So I'm not here convinced that you have metastatic disease. So with this positive test, and if you think that, you have, and these positive tests are really real or almost real, you have to have a clonidine suppression test to rule out if you have for example, activation of so-called sympathetic nervous system that will distinguish between, whether you have a pheochromocytoma / paraganglioma, and whether you have something else. Also, the last comment, sleep apnea. If you have a sleep apnea, you will definitely have positive biochemical test, and you can be confused, with the that can be actually the first sign of metastatic disease.
With that, would you recommend that person has a dotatate if they haven't had it in this case?
No, I would definitely. I don't know what the elevation, of metanephrine is, because I don't recommend catecholamines to be measured. And Dr. Taieb also mentioned it. So most likely clonidine suppression test if necessary. Okay. This would be definitely my first. And of course, to look at the drugs that the patient or medication that the patient is taking, so before that, I would not go into any imaging whatsoever.
Okay. And a great segue, a couple of questions have come in about the position for blood draws. And is it absolutely critical that you have that resting period in a supine or supine position prior to the blood draw?
The answer is must. Okay. And if you cannot have it, yes, I understand, because many of the patients cannot, because, in the university setting, other setting, it's different. You are sitting, so on the chair, they are doing the blood draw, but then you have to use the different upper reference limits. Those upper reference limits were published by Dr. Eisenhofer and by Dr. Landers. And I think that there must be used, because, the values may be by 30 or 40% higher than, the normal value. So they will be above the upper reference limit, and you feel, oh my God, I have a pheochromocytoma / paraganglioma recurrent or metastatic, but you don't have it. You just were sitting in the chair, so you were not resting. So if you may, and I know that is difficult, I'm realistic, in that, so you have to consider that you will need to use the different upper reference limits. I mean, not you, but your doctor.
Thank you for clarifying that. The next question is there any research regarding if IVF is considered as preventative for those with a confirmed mutation?
There is not research, but yes, my patient, they have a IVF, to avoid, so having, their, the children, the SDHB mutation. This is very highly specialized, approach, and they have to go to very specialized centers. But there are several patients, and maybe if the person is really considering something, and the person will contact me, I will try to connect the person with somebody else in case that person will agree, to get, some, I would say, more detail and useful information.
Okay, thank you. Let's see, this one is about, do all patients with Pheo or Para have a higher chromogranin A level?
Dr. Taieb, so it's like, yeah, so.
I have to say that our endocrinologists do not perform chromogranin A for all patients, but it is clearly linked to the tumor size, especially for chromocytoma, but it is not a very sensitive. For me, it's not really a very sensitive marker, but I think Karel have a greater experience in this kind of marker. Could you comment?
Yeah, chromogranin can be good, for some head and neck paragangliomas, for those that they don't produce, for example, metanephrine or normetanephrine, and you don't have a measurement of 3-methoxytyramine. Then as also Dr. Taieb, alluded into. So, and chromogranin A can be a really good one, and good, I would say, substitute. Okay, so because, it's not very, I would say, very specific, because it can be affected, by many actually conditions, and but it can be useful, especially in certain situations, including head and neck paragangliomas. Again, it's not perfect, but if you don't have a 3-methoxytyramine, you can use it, including monitoring of the patients after therapies.
Thank you for that. This person said they noticed that SDHB and D guidelines before they entered today. Are those two variants more similar than SDHA and C?
Well, we already talked about that. D is, I will tell you, B is bad. In my view, if somebody develop, the pheoparaganglioma is awful, because I told you, they cannot be, well treated sometimes. The response is, if they develop metastatic disease, it's a little bit complicated, but these are experience here. I don't want, to, maybe many physicians, they have a much better experience that we have here, at the NIH. And C, I would say it's cool. It's okay. So C has, the best, I would say, the best outcome. And D, like double. Some they are doing well, some they actually develop metastatic disease. I think it's like, between D would be somewhere between B and B and A. So it's not, or maybe, will be D is better than B and of course A, put this way. So that would be most likely a good response. But the D, at everybody sometimes thinks, they are behaving well, not really. So there are some, patients that they may actually develop pretty aggressive disease, but not too many like with B or A.
Okay, and Dr. Taieb, while you were presenting, somebody had a question, a note of why should the vocal cords be immobile?
Yeah, you have to consider that for vagus nerve paraganglioma, there is a very close relationship between the nerve and the paraganglioma. And vagus nerve paraganglioma could induce, without any surgery, a vagus nerve paralysis, a vagus nerve lesions, injury that will lead to vocal cord paralysis. So, you know, the fibers that go into the vagus nerve will go into the larynx, you know, and will be responsible of the mobility of the vocal cords. So when you have a vagus nerve paraganglioma, without any surgery, you could have a vocal cord paralysis. So it could come spontaneously with the disease. And if you have already a vocal cord paralysis, you could perform surgery because you have already the paralysis of the vocal cord. But if there is no vocal cord paralysis, you have a very high risk, almost complete risk of surgical complication with a vocal cord paralysis. And in the context of SDH mutation, with a very high risk to have a contralateral vagus nerve paraganglioma or a high risk to develop with time a contralateral vagus nerve paraganglioma, this could be really a very bad scenario to induce vocal cord paralysis with surgery.
Thank you for clarifying that. The next question is altitude the only thing that increases risk for SDHB patients, or are there other factors that can increase the risk of tumor growth?
I think I responded to somebody, you know, so it's the altitude definitely, but, you know, altitude is, you know, equal to hypoxia. When is hypoxia coming? If somebody is smoking, yeah? You know, so that would be also some type of hypoxia in somebody, you know, is very good athlete and is running, for example, marathon, you know, hypoxia or strenuous exercise. So you can do, you know, many things, but avoid high altitude and of course, let's say, do not assume that you are smoking, but avoid the exercise that will actually put you in, you know, the hypoxia. So you cannot catch the breath, you are absolutely exhausted. You can bike, you can swim, you can do whatever you want, you know, but the way that it will be more like leisure recreational than, you know, just to make, you know, some very specific records and beating somebody else, you know, so it's definitely not.
Okay. Thank you for that. This question is, if you've had a metastatic disease and you underwent removal of the tumor, residual disease is in bone, they underwent Lutathera, follow-up PET is showing those spots as more active. They're wondering if there's any further treatment recommendations or if everything at this point is experimental and screening.
Well, Dr. Taieb, I'm pretty sure will comment, and I can comment also a little bit, but he specializes in nuclear medicine and therapies.
Yeah, so the idea is to perform, could you please clarify the question, is to complete after surgery with Lutathera and?
So they had, they underwent removal of tumor. They have disease in the bone. They had Lutathera, and the follow-up PET from that dotatate is showing the spots are more active. Sorry, another question came in, bumped it. Is there any follow-up treatment, or is everything at this point experimental?
Okay, so the question is to after 4th cycle of Lutathera, and there is additional hotspot, and the question is follow Lutathera, right?
Yes. Yes.
It's for you, Karel. This question is for you. It is after Lutathera.
So Lutathera, you know, so first of all, you know, if somebody has a bone lesions, you know, did the patient need it? Did the patient need really Lutathera? Because if the patient, for example, has, you know, few bone lesions that are small, even, you know, 10, 15 small, you know, I would definitely not use Lutathera, okay? Unless those bone lesions are using, you know, in certain way, I mean, growing, you know, like they have a, you know, moderate or low grow, you know, otherwise most likely not. If, you know, those lesions are growing and there is a problem, yes, you know, so you can consider, you know, the For some lesion, you can consider local radiation, and Dr. Taieb was talking about that. But if necessary, and so there are many bone lesions that are growing, and it's really fast growth. You have to consider chemotherapies. It's really difficult to answer unless we would review the entire situation here. But you have to be careful to be treated with lutatheraform bone lesions. If you have even 10 lesions that they are very small, you don't need it. You just will watch those bone lesions, because you can use lutathera later on when the things are becoming a little bit more complicated, in case that they may not.
Right. Thank you for that. This question was, could you help define metastatic paraganglioma? If I have multiple head and neck tumors, is that considered metastatic?
So if you have multiple head and neck paraganglioma, it's not a metastatic disease, just a multifocal disease. In patients with SDHD, many patients have multiple head and neck paraganglioma. It is clearly not frequent, but possible in the context of SDHB. It is very infrequent in the context of SDHC. So if you have multiple lesions in the neck in the context of SDHB, you have to be sure that it's really primary head and neck paraganglioma, and it's not, for example, metastatic lymph nodes. It's possible. In the context of SDHD, yes, it's classical to have multiple head and neck paraganglioma, but it's not. It's clearly, and they should be clearly distinguished from a metastatic disease. It's not the same condition. Yeah.
Okay, thank you. Just two more questions. If a patient has metastatic Pheo and then a relative has bilateral Pheo and a pituitary tumor, but no known gene when tested, is it likely that there is an unknown gene involved?
No gene were tested. Yeah, I would say maybe, so the patient, I think, maybe is thinking about that the gene, the patient was tested, but there was no results that would point it towards a specific genetic problem. Yes, I'm pretty sure that there is a gene that is involved. And especially for bilateral pheochromocytoma, there is almost impossible that somebody with bilateral pheo would not have a genetic disorder. But sometimes, I have to tell you honestly, in few patients, we are still failing in terms of finding, specific gene or specific, genetic aberration that would explain, the development of the pheochromocytoma. I would repeat the testing and see, what is happening, and maybe I would also look at the here, mosaicism, maybe possibly, so we would need, to do some special testing, from different tissues as well.
Thank you. All right, last question to wrap it up. Dr. Pacak, you mentioned earlier about hypertension. Could you please explain why hypertension is not part of the signs and symptoms of pheopara?
Yeah, that's a very good question, because if you take, for example, the population here in this country, how many patients they have hypertension, about 30% of patients, yeah? So of course, most of them will not have any pheochromocytoma paraganglioma. And most of them will never come up, with certain symptoms and signs related to catecholamine excess. I know that you would argue with me if I have a, for example, hypertension that is, problematic in terms of, treatment. I have a headache, I have sometimes dizziness, etc. That's correct, but, the hypertension, so that only comes with specific symptoms and signs related to catecholamine excess. Why do you have, put this way, why do you have a hypertension if you have a pheoparaganglioma? Because you have a high catecholamines. And high catecholamines will not only, be related to your hypertension, they will be related to sweating, they will be related to tremor, they will be related to anxiety, nervousness, most likely, weight loss, being pale, as I mentioned. So you will have to have something on the top of the typical, so we call primary or essential hypertension that, in the population, it's, I would say very common, or, hypertension because somebody is, for example, obese or has, something else that is actually leading, to hypertension. So on the top of the hypertension, you have to have something else to consider that you have a pheochromocytoma paraganglioma.
Thank you for clarifying that. Thank you to Dr. Pacak and Dr. Taieb for your time and your dedication to our patients. This webinar will be available in a few days on YouTube and on our website on Pheopara. Sign up for our e-news and follow us on social media. Today's webinar was made possible by the generous support of people like you. If you find webinars like this one valuable, you can donate to support the program at www.pheopara.org. Finally, thank you to everyone who attended today. We greatly appreciate all of you for participating.
So thank you so much for your invitation, and to Lacey for moderating, the session. It was absolutely great. And I would also thank Pheopara Alliance and, of course, be able, to be with my long-term collaborator and wonderful friend, Dr. Taieb.
Thank you so much. It was an honor to be here, and I hope that all us and will help the patients.
Thank you.
Thank you.